Now, I'm very pleased to introduce the moderator of our first panel, which is Fairness is Excellence, Dr. Kathy Craven, and which will be discussing equity considerations and their intersections in health research and care. And Dr. Craven is a professor of medicine at the University of Toronto and a board member, OSU board member.
Thank you.
Take away, Kathy. You don't need this.
Good morning, everyone. I just wondered, while I'm doing introductions, could I ask the panel members to come up and be seated here on the stage? So Nav, Paula, Astrid, Sujitha, Sharon, Justin, and Joe. Please make your way up and find a seat, and hopefully you can maneuver around me. Today is a day really for celebration and reflection. If you look at what has happened since OSU was conceived in 2011, launched in the fiscal year 2013-2014, when OSU was founded was the time at which there was the height of the Me Too movement. We've seen the rise and fall of ISIS. We've lived through together the COVID-19 pandemic. We've witnessed the horror of and rise of the Black Lives Matter movement following the death of George Floyd. We've had the movement on reconciliation with implementation of the Truth and Reconciliation Commission. We've had war around us, an attack on our Canadian culture, and a movement to really consolidate. So I see today as an opportunity for Canadians to consolidate the great work that we have been doing related to equity. And I just want to define for those in the room that maybe don't use this term every day, that equity really looks at creating opportunity for everyone to reach their full health potential without being disadvantaged due to personal, social, or environmental factors. And of course, those of us who are well into the patient engagement movement see people through an intersectoral lens. We see people as parents, as children, as caregivers, as well as their demographic, social, and environmental context. And that environmental context is becoming increasingly important with all of the natural disasters that have been going on around us. You will hear this morning ways that people have looked at research through or explored research through one or more of the intersectoral lenses on the screen. And you'll hear how OSU has been advancing health equity before it was cool and before it was politically correct. So I hope you'll join me in celebrating as our panelists present, and I'll ask Nav to get us started today with presenting the model.
Great, thank you so much. So wonderful to be here. I was just saying at the table, it's very difficult to imagine an event like this happening 11 years ago. So really glad to have been part of the journey, and really delighted to present on behalf of the Fairness is Excellence Working Group, our framework. And the idea behind fairness is excellence, and you can advance to the next slide if you like, is that you cannot achieve excellence in health research without considering fairness, and we need to consider fairness in the way that we do research and patient-engaged research. So we developed an equity framework called Fairness is Excellence that goes through the way that we do research. And so we as health researchers and healthcare providers are not above considerations around fairness and equity. Not only should our products be fair and equitable, not only should we recommend that care be provided equitably, but we should also undertake our research in ways that reflect that. So when it comes to selecting research topics, writing research questions, we should really engage in topics that are likely to focus on and advance equity. Certainly when we're engaging with the public and patients, we should do so in a way that's equitable and that reflects the diversity of the populations we aim to serve. The framework also goes through how we can support, and you can advance to the next slide, please, staff and students in a way that's fair and equitable. It goes through the conduct of research, analyzing results, and exchanging knowledge. Next slide, please. We've developed a module that can be completed online. We've also had in-person sessions where you'd go through and reflect on your own work and think about how some of the principles laid out in the equity framework may apply. Next slide, please. And again, I'm really pleased to be presenting on behalf of a large group, and I'm really grateful to the OSSU and Vasanthi for supporting this work going back years. And in closing, we were asked to reflect on the next 10 years and what work we think needs to be done in the next 10 years and where we hope to be 10 years from now. And I think one of the current focuses of the Fairness is Excellence Working Group is on funding. And right now there can be sometimes a discrepancy between statements made by institutions with respect to how important they think equity or fairness is and how much money is dedicated to promoting equity or fairness. So I'm going to intentionally avoid using the phrase, show me the money, but hopefully in the next 10 years, we see funding decisions that represent and are concordant with stated priorities around fairness and equity. And so I just want to close by saying I am really grateful to Vasanthi and the OSSU for supporting this type of work going back years. And as Kathy said, long before it was in fashion.
Cool or sexy. Yeah. All right, I wanted to thank Nav. For those of you who don't know, he's the Canada Research Chair in Health Justice and a clinician scientist at St. Michael's Hospital, or what is now called Unity Health, and the lead of OSSU's Fairness is Excellence initiative. And I encourage you to look at the resources he has provided. Our next speaker is Dr. Paula Rochon, who is the founding director of the Women's Age Lab, a geriatrician and senior scientist at Women's College Hospital and ICES. And she is also the lead of OSSU's Sex and Gender Plus initiative, and I'll turn it over to Paula.
So thank you so much, Kathy. So I'm pleased to talk about our sex and gender research support service that we provide to OSSU. And we've had the honor of being part of OSSU since the very start. So thank you so much, Vasanthi, for your vision in putting this group together. I think it's amazing what you've done and the impact that the group has had sort of across the province. So in terms of our sex and gender support service, one of our key activities has been that we've helped investigators improve their grant applications. So we've provided support for how do you get sex and gender included in your proposals. And I think it's fair to say that we've reviewed many proposals, multi-million-dollar projects, and I think we've had a real impact at improving the success rate of these projects. And I think as part of this work, we've also helped with capacity building. We've created a research toolkit that I'll talk a little bit more about, and we've provided assistance with knowledge translation activities. And all of the work that we do has included patient partners, which have been so important. Now, we're talking today about some of the inequities, and through our work, we really want to try to work to reduce health inequities. So, for example, in the area that we focus on, which is around women and aging, too often older adults, and especially women, say that they feel invisible. And that's something that we need to change. And we know that females are different than males, and we know that people who are 65 are different than people that are 95. And there's so many other important intersections that we need to consider. And so by thinking about sex and gender and the intersections with age and the many other intersections, our work is really helping to address these inequities and ensure that all older people and women in particular are visible. Now, one of the things that we do, and one of the things I'll talk about, is some of the work done through our Sex and Gender Plus support service. So we've created a number of, I think, very impactful learning modules. and they're part of the Health Researchers Toolkit. And when I say we, I actually mean Robin Mason, who's been working with us for many years, as well as Joyce Lee, who's been working more recently, have put together these beautiful resources. So for example, these are e-learning resources, but they also have a PDF form if you'd like to work with handbooks, and those are really quite beautiful resources. And they've also been translated into French to make sure that they can be used across our country. So there's a series of modules we've created. What Gets Counted Counts is the one that's in blue here. There's also one on intersectionality is something that we really need to think about as a research lens, and one on making research more participatory. And again, patient partners have been invaluable in ensuring that these resources are as impactful as they can be. Now, as Nav said, we were asked to talk about what the directions might be for the next decade. And I think it's fair to say for this audience, I think we'll all agree, that sex and gender, and perhaps even research for that matter, has never been more important than it is now. And so moving forward, I think we need to continue to reinforce the importance of sex and gender and research, and continue to lead in this area, and ensure that there's so many more intersections that we need to include in our work. So thank you.
Okay, thank you, Paula. Our next presenter is Astrid Goodman, Senior Scientist and Chief Science Officer at ICES, and holds a Tier 1 Canada Research Chair in Child Health Services and Policy. Over to you, Astrid.
I'm happy to speak from here.
You just yell when you're ready.
Sure. So I'm delighted to be here. Also, I'll echo the gratitude that we have to be, part of OSU and the support that we've had. I would say we are ICES, not the ISIS that, that Kathy mentioned that has hopefully gone away. I'm sure most of you know, but I'm just going to put a point to frame the conversation about some of the work we've been doing around health equity research at ICS. So ICS, I think most people know, we're an independent research network across the province, core funding by the Ministry of Health, and we hold almost all the health administrative data as the backbone of our data repository, but we have demographic and many other data moving into social data as well. Next slide. So what I wanted to do was just talk very high level about a framework that we had developed which we did to respond to calls around the appropriate use of race and related data. And when I talk about related, that would be things like immigration data. I will just say as a caveat, Sujitha, my colleague sitting to the left, is going to talk about Indigenous data. This is not about Indigenous data. We have a very mature framework and a way of working with Indigenous organizations and communities that's quite separate, although we certainly borrowed conceptually quite a bit when we started to do this work. And this work really started during the pandemic for a few reasons. So one was, just the horrendous racial inequities in COVID that were in front of us, but not easy to measure. And that is because we don't routinely collect race or a lot of demographic data in our administrative data. As some of you may recall, some of the public health units, including Toronto, did start to collect some of those data with the COVID testing data. And then that became provincial. And at the same time, a group that had been advocating as individuals for decades, but who sort of consolidated as the Black Health Equity Group, who had been, again, calling for the collection of these kinds of data, also came up with a very important framework, which wasn't just about the collection of data, but was about community involvement in those data, how those data were going to be used, and the governance. And they called upon organizations, including ICES, to really, both join them in the advocacy, but also, where were we going to be in that space and in that framework. So we needed to do a lot of internal work around this, and we did a lot of consultation, internal and external. We ran a people's panel to really understand what the public thought about this, and our framework has 4 pillars. So one we're calling anti-racist research, which is really about ensuring that there's community that's part of that research, and that could be in a range of ways, but that it's also multidisciplinary, so that we bring people in to sort of move what I would call kind of a very antiquated biomedical way of thinking about race into what the social scientists and actually even the geneticists have known for a long time about race being a social construct. Community access, really, really important. Community governance of data, we could talk all day about this, it's very complex. And then accountability. Next slide. So just really briefly, things that we have tried to do. So we don't require, but we are certainly trying to encourage as much community engagement in projects using race-related data, and to be honest, in a lot of other kinds of health equity work. So we have a fantastic team who have provided a lot of resources, they provide consultations, and we're just trying to move the ball on that. We've also provided some capacity building in the form of a health equity expert who helps do consultations to teams around their projects. And then to me, and this is really key, we need to engage with more social scientists, qualitative researchers, equity scholars to be, I think, doing the kind of work that we want to do in an appropriate way. Next slide. The next piece, and Nav didn't want to talk about money, but this is, what I would say is like putting your money where your mouth is. So, we're really fortunate because ICS has a funding stream where we do free, data and analytics for the ministry, for health service organizations and community organizations. And we feel like that's a fantastic vehicle for community organizations to request data that they need to do their work. But we need to make sure that they know who we are, and we need to, make sure that they understand the kind of data that we can work together. And even though I see this very much like we're serving them, but boy, do we learn a lot. And Nav talked about prioritization of, research questions, making connections between community organizations and researchers. That's good for everybody, and so that's a big part of what the team's been doing is, just trying to move on that. Next slide. Community governance, as I said, this is a huge, huge topic, very important, I think, in terms of maintaining accountability, being an appropriate steward of the data that we have, making sure we reflect community values in how we do our work. And then also, as a research organization, just giving researchers sort of some guidance on how to do this. Next slide. So in terms of sort of the next 10 years or future directions, so we are kind of continuing on this path. Relationship building, trust building is a very important part of that. And again, we want to do this as an organization, and then and have our researchers come along with us. Sometimes we do it through their connections, but I think it's important that institutions do a lot of this kind of work, not just individual research teams. We are now co-designing a community governance model. We are focusing on the immigration data to start, and we are doing this in consultation with communities. So that's ongoing work, and we should have something, in draft form, and very interested in comments and consultations, hopefully in the next sort of 6 months. We need to figure out how we measure, what we're doing in a way that's important. And then again, as I spoke about, diversifying the expertise that we need. So some of that expertise is about community expertise, but some of that is also scientific expertise to really be doing this work well. Next slide. I will give a shout out to our fantastic public and community engagement knowledge translation team. They are all in the audience, so please engage with them over the course of the day. So, thank you very much.
Awesome, thank you, Astrid. Our next presenter this morning is Sujitha Ratnasingham, who's the Director of Strategic Partnerships at ICS, where she collaborates with First Nations, Métis, and Inuit leadership. And would you like the clicker? Would you just yell?
I'll sit here if that's okay.
Okay, perfect.
Thanks so much. And thanks so much, Vasanthi, for inviting me. I am a Plan B. Dr. Jennifer Walker unfortunately couldn't make it, but I've worked closely with her over the last several years to expand the work that we've done with First Nations, Métis, and Inuit partners and communities. So although ICS has broader commitments to Indigenous communities and partnerships and leadership, today I'll be focusing on First Nations research and data sovereignty. That's some of the work that's been done and funded through OSU. Next slide, please. And this framework is a framework that really underpins the work that we do at ICS for First Nations data, as well as First Nations projects and partnerships. I have to say that this was really co-developed with the Chiefs of Ontario for the work that we've done, and all of the work that's possible in this space has been through partnerships and trust that's been built over several years. As you can see, fundamental to this work in the center of the framework are First Nations principles. So these are the data governance principles of OCAP, ownership, control, access, and possession. These are the First Nations Information Governance Center's principles that they developed. And from that center, you can see that there's 4 quadrants that kind of come out from there. So the top 2 are ethical relationships and data governance. These 2 work in tandem together and really are a balance to each other. So on the top right, we have data governance, and this is done through things like formalized data governance agreements with the Chiefs of Ontario and other First Nations leadership organizations. And on the left, we have ethical relationships, things like Indigenous research ethics, ensuring there is sufficient and meaningful community engagement for projects and mutual capacity building. And on the bottom, we have the methodology and approaches. So trying to incorporate Indigenous perspectives of models of well-being, as well as identifying data gaps, which I'll speak to in a moment. And on the bottom left has been the conduct of collaborative research projects, as well as service model data requests from communities. Astrid spoke a little bit to the funding stream that we have through the Ministry of Health that allows us to conduct projects on behalf of partners. So we have some dedicated funds to be able to do the work on behalf of communities. Next slide, please. And this is just, I'd say, an example of some of the projects that have been possible through the fundamental work in the framework. And I, again, have to just really highlight the importance of the work that Chiefs of Ontario has done to be able to bring a copy of the Indian Register from the federal government to ICS. And that platform has enabled all of this First Nations work to happen, including, and I'll highlight the one in the bottom left. And this is a collaborative project, a collaboration of First Nations communities in Northern Ontario that have worked together to identify priorities for them and have used data that are held at ICS to answer those questions. So it's really a great example of community-driven research that has been made possible through the work with Chiefs of Ontario. Next slide, please. We were also asked to speak to some intersectional issues and progress made. So some of the issues that we've identified, so there are, I think, well-known gaps in access to services, and what this leads to is inequities in the data, and these data are being used for decision-making and policy development. So some examples of that are the communities, so First Nations communities, on the borders of Manitoba and Quebec. They often are receiving services in other provinces due to distance or easier access to those services in hospitals. We also have data that are siloed for First Nations in the provincial and federal system. So these are often not connected, so we're not able to get a more holistic and comprehensive look at health. As well, it's also highlighted the need for expanded data beyond health services. So not just looking at health as its own entity, but understanding the importance of social services and other types of social factors in health outcomes. So some of the progress that has been made, we've been working on developing algorithms as well as redefining some of our definitions so that we can incorporate things like various models that people receive primary health care. So in the past, some of our algorithms don't include community health centers or Aboriginal health access centers, which often serves as a primary way that communities receive health care, or nursing stations within communities. as well the collection of data for out-of-province services. So we've worked very closely with the Ministry of Health to be able to bring that data in. So again, when we're working with communities, they're able to actually get a solid picture of what the health looks like for their community members. Next slide, please. So some of the key resources we wanted to share. So I think most are familiar with the OCAP training from the First Nations Information Governance Center. There's also the Indigenous Community Research Partnerships, and this is done through Queen's University. There is the Skipper Indigenous Research Level of Engagement Tool, the IRLET training from the First Nations University of Canada, as well as a podcast series that the Chiefs of Ontario does, which is called Voices of Sovereignty. Next slide, please. So directions and challenges ahead. Some of the biggest things that are happening right now relate to the development of an Ontario First Nations Regional Information Governance Centre. And this is being undertaken by the Chiefs of Ontario. The current phase that they're in is engagement with First Nations communities to understand their perspectives on what this could look like and what the governance of the centre would be. Ways that ICS is supporting that work is that in the Chiefs and Assembly resolution related to the centre, ICS has been noted as the interim model because we have the data governance agreements in place and the data infrastructure to support this work. In addition, ICS plays a supportive role for the First Nations data table. So those that aren't familiar with that, that's a table that includes First Nations leadership. Sean sits on it as well. In addition, it includes representatives across ministries in the provincial government. As well, that we also participate on the Data Champions Advisory Committee. Michael sits on that, and that committee really serves the role of guiding the work in the development of this centre. Next slide, please. So thank you so much for your time. I've put Jennifer's contact information there as well, and the Indigenous Partnerships Data and Analytics Department, ICS, and my contact information. Thanks so much.
Thank you, Sujeeta. Our next speaker is Sharon Johnston, who is the Scientific Director and Associate Vice President of Research at the Institut de Savoir Montfort and the lead of OSU's Francophone Initiative. So welcome, Sharon.
Thank you. Since we have a trend here of saying thank yous, I'll start by saying I've been in this role for just over a year, but I really inherited the role and quite a bit of wisdom and community connections from Alain Gauthier from Laurentian, Denis Prudhomme, who's now at New Brunswick, and many of the community leaders they'd worked with for a decade. So I represent quite a team here. For the Francophone Patient Engagement Initiative that is now based at the Institut du Savoir Montfort in Ottawa with the mission of engaging Francophone patients in research. Next slide. So 4.5% of our province, 600,000 Ontarians identify themselves as Francophone. Some been here for a month, some trace their roots to many generations. Francophone is one of many identities they might have. Many want to contribute to improving the healthcare system, certainly trying to secure access to healthcare in their preferred language and improve outcomes for their communities. Most of the research we do, the brilliant people I have the chance to work with on a regular basis work in English. Our consent forms are in English, our teams meet in English. So they just don't see an opportunity to meaningfully connect. I work 2 days a week in my second language in French. I understand the barrier that poses. So one of our primary goals through the Francophone Patient Initiative is creating opportunities for Francophone patients to engage in research. But that starts with increasing the visibility of opportunities. So with the help of OSU to tackle that visibility piece, in February, OSU helped the Department of Family Medicine at the University of Ottawa bring a tremendous colleague from Quebec, Annie Leblanc, who runs the OSU training program platform, who's predominant, based in Quebec. Most resources on the website are in English. And she came, delivered a bilingual presentation, and some of our Francophone patient partners attended and said this is the first time they've actually understood what this is about. They really liked it. They've got a lot of opinions. They'd like to share more. A month later, with the support of OSU, the Montfort Hospital had its first health research day in French. 100 people, 6 patient partners presenting on a whole range of topics. And our Francophone patient partners were invited to meet all the students who were presenting posters and give out the best elevator speech award. That image is the future. That's a Francophone researcher superstar. He will make a big difference speaking with one of our patient partners and our keynote speaker. And afterwards he said, how do we do more of this? He's a basic scientist. He doesn't really talk with patients that often, and he said it really made me think about the kind of work I want to do. So that's part of what this initiative is increasing the visibility, which then opens doors to opportunities. Next slide. So this started it started really 10 years ago and has grown. The COFRE initiative is really focusing first on trying to build a network of Francophones who would be interested in hearing about research opportunities. So we have almost 70 patient partners who say they agree to let us send them emails about opportunities. With that, we've developed a consultation service. Whether it's English-speaking teams, Francophone teams, they can do a webinar. We'll help them translate all materials, invite patient partners, and ask them questions. Are these the results that matter? How would we reach your community? What are the questions that matter to you? To try to facilitate and build that bridge for Francophone teams, but also for teams across the province. And we've got expertise on capturing language as a health variable. I don't think many people would get funded research without exploring sex as a health variable, age. We need to start tackling language in the very same way. Obviously, I represent le français, but there are many linguistic minorities in this country. And so feel free to reach out if you have any questions about capturing language as a variable. Next slide. So this is just some of the examples of some of the tools that we have for the consultation webinar type things. It's email, contact us. We'll help you set it up. If you don't have a French-speaking representative, we'll try to accompany you there to facilitate the Francophone patients engaging with you. So lots of resources to support you there. We'll help with recruitment materials, language adaptation to try to help you reach the Francophone community. Next slide. So questions, commentaires en français sont bienvenus. We'll translate and make them bilingual as we always do. But for next steps, the visibility piece is really just starting to take off, where we're trying to be very explicit that there's research that happens in French. There's opportunities for Francophones to participate in research in their language. We need to increase that. That means we have to build more bridges with teams that are working largely in English to help them reach Francophone patients and help Francophones engage with them. We welcome your advice, your questions on that, or consults to help with that. And I'm not going to say this last one just because I'm sitting beside 2 brilliant people from ICES, but a few months ago, some community organizations came to us because we have the visibility of caring about the health of Francophones and said, we need data on what the needs are of our Francophone patients. We can't advocate for services. We don't know what they need. We don't know what they get. So I said, I can help put together the smart people to help you answer that very important question. And then we went to ICES, and the amazing people there said, okay, we can help you do this. And we're going to get you the data, and we're going to answer the question together. And we're not going to charge you, because that community didn't have a penny to put into research. They've got other priorities. That's what we need more of.
Thank you, Sharon. Our next speaker this morning is Justin Presseau, Senior Scientist at the Ottawa Hospital Research Institute and lead of the demonstration project focused on equitable immigrant access to eye screening, a project funded by Diabetes Action Canada. So welcome, Justin.
Thanks very much, and thanks so much for the opportunity to speak as part of this panel. And before I dive into this specific demonstration project and program of research, I thought I might reflect from the start on the next 10 years and my thoughts around that. And the first point there that I want to make is I think that's the point. We need 10 more years. We need, to your point, 10, 20, 30 more years. And the reason I say that is the kinds of trusting, authentic relationships that are fostered as part of conducting patient-partnered research take the time and need the long game, and continuing to invest in this kind of work is needed in order to maintain and sustain the kind of advances that we're already making. And hopefully I can give you a sense of a bit of a deep dive relative to some of the other presentations on how we've tried to accomplish that so far in supporting and bridging health equity gaps in people that have immigrated to Canada to get their eyes screened if they have diabetes. Next slide. So what is this all about? Just to scene set a little bit, this is about diabetic retinopathy. It's the most common microvascular complication for people who have diabetes. At some point in people's lives, if they have diabetes, chances are they will develop some form of retinopathy, which risks progressive vision loss, blindness, and associated consequences. Next slide. Thankfully, some of that can be mitigated through routine annual screening. But as you might not be surprised, screening rates are not optimal across the general population, and a substantial proportion of people with diabetes have never been screened. And this is particularly the case, especially the case for people that have immigrated to Canada. That being said, Canada is, at least 1 in 5 people in Canada right now was born outside of Canada. I think our identity as Canadians is characterized by immigration, something that we should be proud of and something that we should be supporting people that are coming in or have been here for a long time in receiving the kind of services and care as the Canadians they are. This is particularly the case that we've identified within the context of diabetes eye screening. Data from Ottawa from a few years ago that justified some of this program of work highlighted that 40% of people that were immigrating to Canada that had diabetes had not been screened in the last 2 years, and so justify this work. Next slide. So what did we do? We've been, over the last 8 or 9 years, been on a program of work that is really from the ground up, partnered with people from the community that have immigrated to Canada, that speak different languages, that have diabetes, to build up a complementary service to support their eye screening needs. So we started off by doing our homework. We did reviews of the literature on what might stop people from getting their eyes screened, and what does the trial literature tell us around what strategies are effective in supporting people to actually attend. And within both those literatures, almost nothing from Canada, and very few amongst those from equity deserving groups generally. So that justified we need to do our homework with actual people. And so we did interviews in preferred languages in Urdu, Mandarin, and French from people that have immigrated from some of the areas of the world that are contributing most of the immigration to Canada, to surface some of those barriers that are experienced within that. That justified then building up, again in partnership with people from the community, as well as healthcare providers, a new community health center-based screening program that connects the diabetes education program in Ottawa, that is citywide, and provides screening services in the community health center in a preferred language. And the images then get transmitted to the Eye Institute at the Ottawa Hospital for follow-up if needed. So that integrated care model established from the ground up with direct input from community partners. That's been piloted for feasibility and acceptability, and now we're in a portion of the work that is supported by OSU in expanding this work to equity-centered scaling to additional languages, including self-referral options, and using the data from within the diabetes education program across the city to case find and invite people to come in to get their eye screen in their preferred language. And that is being evaluated using the framework that Nav presented, which I'll talk about on my next slide. But what I wanted to highlight is this didn't exist 2.5 years ago, and since then we've screened over 450 people that probably wouldn't have been screened otherwise. I've identified a number of cases of retinopathy who have been then followed up. And we have materials and services tailored to English, Français, Mandarin, Spanish, and Arabic, and referral pathways from primary care, as well as the Newcomer Health Clinic in Ottawa. Next slide. And so we're now using, as part of our ongoing support of the Community Health Center program, and outreach to the to communities digitally is fully adopting and using the Fairness is Excellence framework across the 6 topic areas that are highlighted. Where equity is foundational in selecting our topic, we're prioritizing ongoing partnerships with people with diabetes that have immigrated and their families as we expand to different languages. We are supporting not only our research team, but the team at the Community Health Center in ongoing CPD and tracking that, equity-focused continuing professional development, and supporting our trainees and staff with an equity lens in recruitment. And importantly, we're collecting data alongside with tools that are introduced in the process of getting screened and with the healthcare partners around specific equity considerations that include, importantly, in my mind, sustainability, because a sustainable new program, sustainability is a key to the ongoing equity in this space, that we don't want just a one and done pilot program. We want an ongoing and expanding program, and building in our analysis from the start to consider those equity considerations. So we found this framework just really helpful in ensuring that we're prioritizing ourselves not only, but also our community partners and our health system partners' equity throughout the whole process. Last slide. And just to highlight this kind of work, this deep dive work, it takes a village, starts and throughout with community partners, with community health center partners, with researchers, and definitely for funding from OSU, from Diabetes Action Canada, who've been instrumental in this work, as well as some CIHR funds. If you're interested in more of the work, QR codes to the program in our research program. Thanks.
Thank you, Justin. Last but not least, Joe Henderson is a clinical psychologist and executive director of the Youth Wellness Hubs Ontario and Ontario's Integrated Youth Services Initiative, and an OSU Impact Award recipient. So welcome, Joe.
Oh, over here. Yeah. See, I did the mic drop before I started speaking.
It's all up from here.
Yeah, there we go. So really happy to be here today. Really happy to reflect on an initiative that was funded right from the outset of OSU, so 10 years ago. And my focus will be on youth mental health. I'm here, I have the privilege of speaking with you today, but the work I'm speaking with you about is a reflection of the work of many, many young people, family members, service providers, researchers, administrators, and others. Okay, so I'm going to give you an example of all of this in action, focused on youth mental health. So we had the opportunity to act on what we had heard from youth and families for many years, and service providers, that there was a significant gap in access to services that would meet the needs of young people. So we all know that the majority of young people, especially 10 years ago, who could benefit from mental health treatment, did not receive that treatment. The question was why, and of course it's multifaceted. The answer is multifaceted and multifactorial. But one of the reasons was that the service delivery system was not designed in a way that reflected the needs, preferences, values of young people. And so we set out to do a pragmatic randomized control trial, co-designed with youth, families, service providers, and researchers, to test a new model of service delivery, co-designed by youth, family members, service providers, and researchers. That became the Youth Can Impact Trial. Now, when you co-design with young people and family members, you run the risk of really recruiting the usual suspects to those roles. You got kind of that professionalization of young people who are looking for something good on their resume. They go to university, they want to get a good volunteer experience. From an equity perspective, it was really important to us that we really think deeply about how do we reach young people whose voices have not been heard to integrate into this really important piece of work that we were doing. How do we find the family members whose voices have not been heard? And so that was a really important piece of the work that we did at the outset, was to think about and reach out to community partners across Ontario to identify young people who could bring diverse perspectives to the table. You'll see here, this is the intervention. This was the test intervention that was part of the randomized control trial. And you'll see noted on here multiple different parts that young people brought to the design of the intervention. We also, many of you in the room are involved in research, probably most of you are involved in research. You'll know in a randomized control trial, the selection of the primary outcome is really a critical decision point. Youth decided on our primary outcome for the trial. That is not commonly done, and that certainly enriched the work that we did. This model of service delivery, we tested it against treatment as usual in adolescent outpatient psychiatry services in 5 hospitals in Toronto. And the results are about to be published. And I'm going to leave you hanging so that you can find the publication once it's published so you can take a look at it. I'm not going to talk so much about the model. I want to talk about what we've done to really bring the value of partnering with youth as experts in their lived experience to not just research, but a broader perspective, how to do that right now, and to really bring a stronger equity perspective to our work through research, through system transformation. We did throughout, and I have a fantastic colleague, Lisa Hawk, Dr. Lisa Hawk, who has contributed significantly to really making this work happen. We documented throughout the work, both in public and researcher and family and youth facing materials and academic facing materials, how to do the work, the value of doing the work, the struggles of doing the work, the challenges of doing the work, and some of those publications are listed here. We tried to make resources that would be practical for other researchers in order to support them in conducting research in the same way that we had conducted the research, and to strengthen it as well, to really keep that focus on equity. So we were very fortunate as we did the Youth Can Impact trial, which had 3 locations. We tested the intervention in 3 community locations in Toronto to attract the attention of government, to really think about, could this model be feasible in communities outside of Toronto? Now, we were focused on Toronto not because we thought that was best, but really that was a feasibility piece. That's where we had started. And so in 2017, we had the opportunity to launch a demonstration initiative to examine the same model of service delivery, or a very similar model of service delivery, integrating structured treatments to get mental health and substance use treatments into a broader model of service delivery, that is an integrated model of service delivery, to expand and do that in 7 additional communities, so 10 communities in total for 3 years. At the end of those 3 years, we were able to show the value of this model of service delivery and the feasibility of the model of service delivery. And since that time, we've been able to expand to 32 funded networks across Ontario with hubs in more than 40 communities. We have hubs in Francophone, led by Francophone organizations, by First Nations organizations. We have small rural communities, large urban communities. And every community, it's about understanding the community's needs, supporting the community to work together to deliver evidence-based mental health treatments, substance use treatments to young people 12 to 25. We operate as a learning health system, and one of the things that characterizes the work that we do is embedding, as a person who straddles clinical work, research, implementation science, it's about embedding measurement in everything we do. Measurement doesn't only have value in the context of research, it has value across the board. And so we have a common data platform and common measures across hundreds of organizations, community-based organizations in all of these communities. That allows us to address equity issues, to understand the needs of young people in each community and in the communities collectively, to compare, say, for example, who's presenting for service to who lives in that community, to build capacity amongst community-based organizations to do measurement-based care, but also to look at their own data, to try and make sense of it, to address gaps that they uncover in examining the data. If that wasn't enough, we've been really fortunate to also have this work together with work led by others across the country to coalesce into a sort of pan-Canadian movement around integrated youth services. The idea being that the conventional model, biomedical model of providing treatment to young people has not been adequate. All of the data everywhere shows that it is not adequate. And so the idea is that by working together across all of these different jurisdictions, we can transform the way young people can access mental health and substance use health treatment in order to achieve more equitable outcomes. And so across all 13 provinces and territories at this point, there have been government commitments to developing integrated youth services, youth wellness hubs being one, inspired by the work funded by OSU. And in addition to that, there's been substantial federal, like CIHR, research investment, as well as Health Canada investment, to allow us to all work together, to bring our data together, both research data and service data, into an integrated data platform that centers the voices of young people as co-decision makers about that platform, that adheres to EGAP and OCAP through partnerships with communities across the country, and will really allow us to address issues and drive better outcomes with and for young people across the country. Oops, wrong thing, I pushed the wrong thing. So I'm gonna stop there. I would look forward to the discussion and answering any questions that people have. Thank you.
I just wanted to start by thanking the panel. We asked them to summarize here. Please summarize 10 years of work in 6 minutes ago, but you must also include resources that would help other people advance equity in their center and location, and tell us what you'd like to see in the next decade. So I want to applaud our panelists, so thank you. That was a tough task to do in a short period of time, so thank you. I'd like to begin by opening up this question to the panelists. In developing new systems and thinking about addressing equity, has anyone experienced or how are you managing the risk of recreating an existing bias or developing a new bias inadvertently, like you're trying to support one group and you end up marginalizing another while you're trying to address the needs of one? Anybody who'd like to speak to that? Joe, I see you nodding your head. Can I call on you? Yeah.
So I think a couple of different things come to mind for me. So Youth Wellness Hubs Ontario, for example, or even the Youth Can Impact Trial, relied on resources that already exist in a community. And what that means as we scale across Ontario, across Canada, is that communities that have low resources, we run the risk of exacerbating those inequities because we're starting from the standpoint of what resources exist in the community. So we are, and I'm thrilled to see Paul in the audience, we're always trying to support communities and young people in amplifying their voices to articulate what their needs are, to bring their needs to the attention of decision makers, and support them in, I guess, using measurement-based like data gathered from measurement-based care and evidence-based approaches to strengthen the work that they're doing and to strengthen their community so that we can sort of think about that. The other piece I would just say is that, I think as we move, and I'm really keen to hear this sort of conversation about AI today, people really think of data, the public especially think of data as pretty objective. And it's, it's been a really interesting journey for me as a sort of expert in data system architecture to sort of really understand how biases can be built into the architecture. And so I would really encourage anyone who's like using any existing, not just kind of ChatGPT, but even, and I think it's, fantastic, the conversation about ICES, for example, is like thinking about whose data are not included in the system. How does the architecture push towards particular outputs that may not be accurate reflections? And so those are things that I think we all need to keep in mind as we move forward.
Thank you.
I'd just comment on actually flipping that, how our work focusing on la francophonie, la santé de la francophonie, really forces us to look at language as a health variable. Where is it? Where is it not? Why is it not there? And then exploring why are we still doing health research, not taking that into account. And it just was natural to look at la francophonie, francophones, and other still basket of allophones. And then how do we explore that basket of allophones? And the work coming out is looking at, it was initiated by the effort to engage Francophone Ontarians with lots of diversity within that basket, but it has led to a really impactful research program looking at language and health. And that, I would say, is sort of the opposite of helping us uncover biases that are sometimes more significant among other linguistic groups.
Thank you. All right, Paula, how can we ensure there's continued commitment and sustainability of sex and gender inclusion through research?
Oh, thank you very much. You know, it's interesting, when we started encouraging people to think about sex and gender in research and providing the supports that we had to them, you know, I think we got a lot of resistance. I think people thought, you know, why am I doing this? It was a bit of an imposition. And as many of you know, it was also became one of the requirements for funding agencies, right? You had to talk about sex and gender, and people kind of did it a little bit, I would say, begrudgingly. They would fill out the little box and have a bit of information. But in part, I think, you know, through the service that we provided to help people look at their grants and think about how they could include sex and gender into it, they started, I think, over time, filling out those boxes more completely. And then, you know, which is what we, of course, wanted, to incorporate it into the whole proposal. And going forward, you know, what we've started to see now is what was originally kind of a chore has become something that people see the value in and are now creating proposals where they're actually designed to look at these particular differences, and they found important differences that really matter to health. So it's important to have, you know, I think these kind of supports and services to get these things going and to work with different agencies to have these different kinds of requirements. And ultimately, I guess what we want to see is people see that value and incorporate it into everything that they do.
Thank you. Justin, I loved your integrated project, and I wondered if you wanted to share some of the challenges you've had, you know, working across sectors and communities and trying to integrate your project.
Sure. Thanks for that question. So, I mean, one of the, it's both a challenge, I guess, and an opportunity, especially as we think about scaling locally in terms of adding additional languages and areas of the world that people are immigrating from, is what that identifies as the constant need to continue to build additional community partnerships. And in order to do that effectively and appropriately, having representation in our research team, which is why in my mind, the OSU equity framework is so helpful to just think through as we're building up our partnership. We have to be building up our research teams in a similar way, so that as we're building authentic relationships where possible, we have representation across the board. So that I think having that at the forefront is you know, creates a challenge in terms of ensuring you have a research program and a pipeline to enable that to happen. But to the question around bias, I think that's knowing that that's something that's coming and paying attention to it, so that you're building up both the research program and the support of the patient partners, I think is one of them. Another challenge, I guess, is, well, it's for everyone, for finding funding for different aspects of the work of the integrated care, between supporting the service to continue alongside the research and evaluation alongside, you know, it's the long game that I'm committed to and what I'm in this for. But it becomes a challenge, but also, again, an opportunity that the integrated models provide, because there are different sources of funding and support that different sectors get access to, and just being aware of what's available and leveraging it where possible, I think, is how our program has been successful so far, but it is for sure a challenge.
Appreciate that. I wondered, Sujitha, I wondered if you wanted to comment about how you see the trust and transparency will be built through the creation and use of data sets going forward.
That's a great question, Kathy. I think the key has been partnership, not having research done about, I'll say First Nations, but really about Indigenous peoples without their involvement. And I kind of will touch on that first question you had as well, because I think it's a really important one where the risk for us was using the same algorithms, the same definitions, and applying it to First Nations people without having the context that really comes from communities themselves. So I think partnership really, like to answer your question right now in the earlier one, that's how you address the biases that have the potential of coming up.
Thank you. Nav, I wonder what you see as our great opportunities in the next decade, beyond show me the money.
Yeah, thanks. Well, I mean, just want to go back to, this entire room is like the opportunity. I think, the OSSU's role in convening is a huge achievement, I think. And, each year that I attend meetings like this, I'm just so impressed by the way patient-engaged research is making important advances in completely different fields and disciplines. So I think there's a lot of capacity here that's been built. And I think, I think probably some of the developments in the United States right now, where, for example, is difficult. There are challenges in getting funding for work focused on equity, could be viewed as a potential opportunity here for us to help our friends and colleagues and advance work that, I think everyone in the world would view as important.
Thank you. Joe, I wondered if you had any words to the wise for those working with youth or adolescent groups.
Sure. I think it's really important to take a developmental perspective. So it's not just, we can't just take our adult patient engagement kinds of models and apply them. We were having an interesting conversation before about how it seems that it's harder to get young people involved in sort of the patient engagement movement. And one of the things I learned from young people is they don't actually identify as patients. Like, that language just doesn't resonate. So it's really starting from the very outset to understand what are the challenges that young people are concerned about and are facing. How do they view their, the capacity they have to contribute? Thinking from an equity perspective when you are implementing engagement. So it can't just be, like I said before, sometimes we see this prioritization of the best model is where youth co-design, or maybe even youth lead. We have youth-led projects, youth co-design projects. And sure, that's fantastic, but that requires a heavy investment from specific young people who are capable of participating, have the resources to participate in meetings and all of those things. So actually, from our perspective, from an equity perspective and a developmental perspective, we actually need a full range of opportunities for young people to engage that include light touch kinds of things like surveys, or popping into a pre-existing youth space where diverse youth are coming together, culturally specific organizations, services for youth experiencing lack of housing, that we have to leverage those kinds of opportunities and have some light touch kinds of opportunities for engagement with young people to amplify those voices and bring those voices into the conversation. So it's really thinking for young people, it's thinking developmentally, it's thinking broadly, it's thinking creatively together with young people, because they're way more effective at thinking about how to leverage social media, for example, to amplify voices. Really that partnership model.
Awesome, thank you. So I wanted to take this moment to really celebrate the work of this panel. You've heard about how they've identified and addressed inequities and tried to remove barriers in specific contexts or with specific groups that are vulnerable or marginalized. You've heard about how they're trying to address social, economic, and environmental barriers to health, essentially advancing equity. And if you think about OSSU and the opportunity that leads from today, there's opportunity for ongoing leadership, accountability and use of the resources, partnership to allow us to look through more of an intersectoral lens and look at more than one reason why a group might be marginalized, and to continue to bring the voice of Canadians to all the work that we do. So thank you very much to our panelists, and please enjoy the break.